Jim Joyce, it's
It's
Wednesday.
Wednesday, man. It's Wednesday. Good to see you, my friend.
Good to see you. I'm still in the good old garage here in New Jersey, and you are now. That background looks
Yeah,
familiar.
this is the Health Beacon Boston office. So
Okay.
not too far from you, but far away from home, far away from Dublin. So
I'm sure Emmy misses you.
yeah, I think so. I get little notes. little notes.
But it's too bad we're not. I don't think we're going to cross paths. I'm going to be in Boston the week of July 12th. So anybody who wants to meet up out there.
Yeah.
And actually, I'm now that my second job is behind me, I actually started getting out, and I had a wonderful dinner with one of the guests on our show, Jeff Berkowitz, last night. Right, 20 minutes away from here. So.
Yeah, that's great. That's great. How'd you guys get on? Did you get on?
Yeah, it was fantastic. We were kind of like, okay, what do we do? Do we shake hands? Do we hug? Do we, it was a kind of strange thing.
Right.
But very quick before we let our next guest in, who I reconnected with after many years myself. So a couple of big announcements, right? Pear Therapeutics with about 4 million projected revenue, spacking out at 1.6 billion. Holy Moses. But I can see the storyline of a biotech there a bit, or biotech-like. Much more just mind blown. And then much more, I'd say, realistic valuation is our friends at Voluntis in Paris being acquired at about 80 million or so, something like that, or in talk. So this DTX space is heating up. I think we'll see more of that, but we'll leave the rest of it to Mr. Bolty Boy Matthew Holt and Jess DeMassa to dissect. I'm sure that's going to be it. Speaking of, I think, digital formularies and other things, so let's let
Glen.
This guy in. So Glen Stettin, our Chief Innovation Officer at Evernorth. Glen is joining us now. Excited to be reconnected. Let's see
if he makes it in. Very good. I'm looking forward.
He's gonna make it in. I am convinced. You can do. There he is, Glen Stettin. Good to see you.
Hi, Eugene. How can you hear me? Okay.
Perfect. Even a a corporate PC works on Zoom. So congratulations.
Yeah.
Hey, Glen. Hey, Glen,
you guys haven't met, right? In any way, shape, or form? I don't think.
I don't think so, Glen. Your reputation precedes you, but I don't think we've met.
Well, nice to meet you, James.
So, Jim, I think, I don't know if I told you, so Glen and I go back probably about a decade now-ish. And what happened, I saw on LinkedIn, the infamous or famous drug report by Evernorth, right? And because now I have this podcast voice, I heard Glen Stettin's voice coming through on the LinkedIn ad. I'm like, holy crap, I haven't spoken to him in a long time. So we just kind of hopped on FaceTime that same weekend and reconnected. So good to have you here, Glen.
Very good, Eugene. Happy to be here.
And Glen, are you responsible for Eugene coming to Europe, or you work with them, or how?
I can't say that I was responsible, but we both were getting started over there at almost the same time for some work we were doing for a company that is now part of Evernorth.
I actually remember before, because we want all of our millions of listeners and viewers to get to know you first and the history of you. But I do remember, since Jim brought it up, I remember it was myself, you, I think Dawn Sherman, heading into, I think it was in Berlin, to meet with Frank Neumann, who I just spoke to yesterday, and we should actually have him. So he's doing well, and I told him that I'm going to have you on the shot, so he sends his regards. So just a little side note of reminiscing 10 years ago.
So yeah, love to hear your background, Glen, and for our millions of viewers, a little bit your career.
Yeah, sure. So I can't say that I grew up dreaming that one day I'd be leading innovation for a health services company based in St. Louis. But sort of the way that I got there, and it's been 27 years already, hard to believe. Is
Wow.
I started out with the intent of being an academic, and in the middle of the AIDS crisis in the mid '80s, went to UC San Francisco to do my training in internal medicine, and got involved with health services research and the whole idea of how do you look at evidence about effectiveness and really, figuring out what's true or not. And, in the whole field of healthcare, right, there's so many people, trying to do really good work about how do we improve outcomes for people, and how do we improve affordability, and how do we improve experiences, and, areas that I've been interested since then. And on a lark, I had interviewed with a company called Merck Medco Managed Care at the time. It was a pharmacy benefit manager owned by Merck. Basically said, hey, where they were interested in population health management and disease management. And I joined really as a clinical consultant. And the big focus was on medication adherence for largely employers and health plan clients. And when I started talking to the clients, they couldn't give a crap about medication adherence at the time, because their drug costs, those were the days of drugs like Zoloft and Prozac and Prilosec. Their drug costs were going up 25-30% a year, right? So they didn't want more medication adherence. They wanted someone to fix their drug costs. And so got involved in utilization management and other things that, maybe, in retrospect, we probably could have thought a little bit harder about experiences that we were creating at the time. But it has solved, once we got the drug costs under control, right, then all of a sudden it became a lot easier to talk about how else we could help to improve the health of the population, which, go hand in hand. And then over the course of time, just, one of the things that I've loved about our company, we've had a couple of, been acquired a couple of times, but I've had the opportunity, even though I'm an internist, a physician, to really be leader in different parts of the organization, including the technology organization. Most of my work has been in product development and product management, solution development. But because as someone who needs an architecture and infrastructure to be able to deliver the things that you need to do to serve clients, to serve patients, you get a little bit sometimes more involved. So I spent some time in the technology organization. I've spent time in our operations. I've been the company's chief medical officer. So every couple of years I've had the opportunity to do something different, although for the last 10 have been mostly focused in the innovation space. And then, as Eugene noted, just prior to getting acquired by Express Scripts, we had an opportunity to start some businesses in Europe, which
which started my European vacation, basically.
Yeah, exactly. But one of the things, a lot of things that I remember there, but one of the things I got to do, we were building a pharmacy business in the Netherlands to primarily serve the EU, but Germany in particular, and had this opportunity to go around to physician offices to really get a better understanding of primary care there. And all the comments that I kept getting back were, you're here from the United States to help us with our health system. What could you possibly know about a health system since yours is so screwed up? And I said, no, I'm here to observe and help understand what the challenges are. I have no preconceived notions about what you should do. And that was part of what we try to figure out.
Yeah. I don't know how many people know that actually Obamacare was somewhat loosely try to be based on the Dutch system, actually. So a lot of the folks that were involved in building Obamacare spent some time in the Netherlands. So I don't know how many of the listeners actually know of this, but lots to improve on. I just one comment that you made, right? And I think it's kind of interesting, right? Because it's traditionally when we talk about digital health, it's been like, if you rewind all the way back, it's a bunch of techies that thought it was something good and then try to find a problem for the solution, right? And I actually think that, back to, I think it was, Dave Snow at the time and Kenny, when you had the technology organization, and that was a little bit of the foresight where actually the industry is now, to put you with a clinical background within that technology and leading some of those components. So that was actually, looking back on it, was pretty visionary.
Yeah, no, there's a couple of different domain areas, right, that are important to have experts, right? And technology and technical is clearly very important, right? User experience, user interface. If I, sort of think about areas where I'm bringing some value, one is as a clinician, right, and understanding the medical piece, but even the medical piece is not enough because you have to have a lot of empathy for the patient experience, right? If we want to provide something that's compelling that people actually want to use, you really have to understand, what it is they're going through and how to appeal for them. And I think still the challenge in all of digital health is how to get people engaged with the solutions, right? Because despite the fact that you may have a great experience, if they won't use it, if you can't make it compelling for them and see why they need it and have to use it. And part of what we've been trying to do at Evernorth is, because we are processing prescriptions in our PBM for people, because we are adjudicating claims, right? We're observing their care, and in pharmacy, it's in real time. So we have opportunity to connect the digital solution and the patient who could benefit from it at a moment that they're receptive. It's I think about it as the teachable moment, or a point in time where they have a need and they have a solution that's available to them.
When you think of like innovation, so when we think of like these chief innovation officers working inside pharmaceutical companies, then trying to, or you have chief innovation officers in, others say even, like an Intel or a tech company. When I think about the systems that you're involved of, how do you think about innovation when you have so many different aspects of the organization?
Yeah, so the first thing that I would say is, right, I hate the word innovation, and I'm sorry that I have it in my title, but I did it to appease my boss who wanted to have someone with the title chief.
Is that still Tim? Tim is still around?
Tim Wentworth is still around? You may want to have him on the show. He could tell you the debate that we had about it. But I kind of view things that it's really for the user, it's for our client to determine whether or not something is innovative, right? It's an outside perspective as opposed to claiming that we're innovating, right? And as part of our company Evernorth, we have business units that are health services, right? So they're used by health plans, they're used by employers, they're used by government. It includes pharmacies, including specialty pharmacy. It includes medical specialty management. So think about radiology and cardiology and orthopedics on the medical side. It includes the pharmacy benefit management. It includes care, right? So we actually have care delivery in terms of on-site health solutions for employers. We have care coaching, we have home care. So it's a diverse set of businesses, and they all have to innovate every day, right? The sustaining innovation to keep up with their client needs. And the way that I sort of look at it as a chief innovation officer across the businesses is I need to take an 18-month, 36-month view of things, as well as how can I connect capability across the businesses to bring things that really are new and disruptive to the market, and in ways that, again, outside in where, what our clients and what the people, right? Over 140 million people we touch in some way across these businesses.
It's crazy to me what you just described, and I guess, it's been, for me, I guess a decade plus that I've actually left the old Medco/Express Script. So this is not your kind of grandma's PBM anymore. It's really evolved into like, what's the North Star of Evernorth?
Yeah, so we look at it as by taking on the challenges in healthcare, our clients' challenges in healthcare, that others can't or won't, or, that really need to be solved. And I have a charter from our CEO David Granani, right? Is not to worry about disrupting the existing businesses. We have to think about what do our clients and what do the people that they serve, the beneficiary of the plan, what do they need and what are the big challenges? So just quickly, affordability, which is even though our costs may be higher than everywhere else, there's still high costs in every country, and and we really are a global company at this point. We're about over 75,000 employees in countries around the world. And then second, I tend to think about the complexity of healthcare that really does two things, right? One is that it means the quality of the care, the outcomes are not necessarily what they should be. And it also means that the experiences are often poor, right? You can have great experiences in healthcare, and you can have terrible experience in healthcare, whether it's using your insurance in the United States and figuring out what's covered, right? Nobody wants to pay attention to it until you actually have to use it. And then it's, how do you get the care you need, right? People tend to be very deferential to their physicians, right? We think about them as, learned intermediary, and right, they're not necessarily on the same page in terms of information. And at the same time, people, benefit from being more involved in their care and asking questions. And so, and then the last piece from big challenges I think about are disparities in care, right? We just have big issues, racial disparities, people who are, poor. They have benefits, often high deductible benefits that make it harder to, make economic versus health trade-offs, particularly when they're under their deductibles. And then there's, I don't want to say intentional bias, but there's inherent bias. And as a result, people don't get the care that they're entitled to. And the outcomes are worse. And it doesn't matter whether it, look at, just some examples of Black women more likely to die in childbirth, or Black and Hispanic people being more likely to have worse consequences for COVID. And people can argue whether it's race, whether it's poverty, whether it's other comorbid illness. It doesn't matter, right? When you look at the outcomes, they're not fair. And we need to over-index on really serving communities that have this disadvantage over the course of time.
Glen, when you think about one of the things that just observing, kind of Express Scripts and Evernorth and, and other big systems, and with the explosion in activity in digital health, like all the investment that's going into these organizations like Eugene and my organizations and other ones, like as a tastemaker, I always think of Evernorth, with the digital formulary strategy, how do you think about that responsibility? Do you guys, when you're thinking about that, saying, hey, if we adopt a certain technology, we might change the whole market dynamic. Do you think that way, or do you just kind of stay practical and pragmatic? Or
yeah, so I would say that we've been very deliberate as it relates to the digital health formulary and our digital strategy. And when I say deliberate, I go back to the big challenges that I talked about in affordability and outcomes. And I think one lens to apply is different disease lenses, right? So what are the big drivers of cost? What are the big clinical areas that have quality outcome issues? So, right, if you do a Pareto chart of where money gets spent, right, by employers and health plans, number one is cardio-diabesity, right? So the consequences of obesity, but you don't have to have obesity to have diabetes, right? Metabolic effects and the heart disease that it leads to. Number two, right, musculoskeletal or oncology, depending on the plan and the age of the beneficiaries. And so I tend to think in terms of we need solutions that help people, depending on the type of problem we're trying to solve, we need solutions that can help people navigate, or that can help people change their own behaviors so that they can live healthier, right? And so if just using oncology or orthopedics or musculoskeletal as an example, right? They're more similar than different. And I say that because if you have back or hip or knee pain, right? And you can go down a path where you get surgery, and most people would like to avoid surgery if they could. And there are things that a lot of people could do to avoid surgery that they didn't need to have. Doesn't mean everybody can avoid it. So it's a navigation issue. In oncology, it's similar, right? You get diagnosed with cancer, it's, rocks your world. And you have to figure out who's going to be my oncologist and surgeon and radiation. And just for chemotherapy, I mean, very simply, right, big problem we have in the US is that if you get your chemotherapy at the hospital versus the same chemotherapy in an outpatient in your doctor's office or in an infusion center, it's markedly different in cost. And it's the same chemotherapy, right? So those are, and for both of those, right, we want to prevent mistakes and complications, as opposed to a disease like diabetes or heart disease and heart failure. There, we're trying to have people change their behaviors, right? And whether it's healthier eating and exercise and what to avoid and taking their medicines and adherence. So there's behavior change, decision-making that has to be improved in both, but they're different types of issues. And so go ahead, Eugene.
No, sorry, just to sort of dive a little bit deeper on the digital. So are you looking at the digital formulary, and I think, you and I spoken, like I did this DTX podcast, right? And should have had Mark Bini on, I think, probably on that topic specifically. But are you guys looking at that in the context of surrounding? So again, right, if somebody who's going through chemotherapy also absolutely has some mental impacts, right, getting through the day. And so are you looking at digital formulary to, I'll say, complement or make it more accessible? And maybe a little bit of what is that even process, right? For a drug, it gets shipped to my house, right? But what happens to that? I don't know. I forget. Sleepy Illness, I think, is on your formulary as an example, right?
Yeah. So when you think about, we have to take a whole person approach, right? Because you are not your disease, but we have problems for people who have a particular disease or a particular condition in terms of their journey through that disease. And sometimes the comorbid factors like behavioral health, play a bigger role versus not. So we look at the digital health formulary as having point solutions that are really important to pieces of their journey, but they're not the whole solution for that individual. And in fact, one of the solutions that we have in the market is something called Health Connect 360. And the 360 is around a 360 view of the patient and a 360 view of the patient's needs. So there we're aggregating all of the next best actions, if you will, right, through analysis of the data, including the data that comes back to us through the digital solutions, right? So really important to us, and a good example is that our care and case managers and our counseling pharmacists have access to people's glucose readings, right? And the focus is really, right, if you're operating within the guardrails of good care and taking care of yourself, we need to leave you alone, right? But if your values are out of whack and you're heading to trouble, right, that's where we can really help you. And those are the people who are most urgent for us to connect to the digital solutions. And where the solutions that have demonstrated value, right, have their biggest effect.
And how do you think about speed, like pace, and driving, because bringing something new into your organization, obviously that's a big commitment. Piloting and assessment and going through. How do you what's your philosophy on that?
I thought you were talking about NASCAR, Jim, for a second. But
I thought you were talking about methamphetamines, but that's different.
Yeah, if that's the approach.
Yeah. So look, none of the problems can wait. So we have to be fast. And I would say that we've had our digital health formulary now several years. Do I wish we had more solutions on the formulary and able to go faster? When we got started, I think a rate limiting step was how do we do the contracting, right? And Eugene knows from having worked for us before, we have a security, right? Really important data security, and how you work with a big company who has clients for whom security and data security and privacy all paramount, right? So we have 613 question, right? Technology, security, right, privacy kind of questionnaire and hurdle gauntlet that you have to get through. And I think that's the same number of commandments that are in the Torah. Right. So for a small company that's just getting started, right, you probably don't want certain giant clients that have the hardest criteria, right, as your first client. And we have the ability to make some exception, right, and doing, right, you mitigate risk on small scale. And that's part of what we had to learn as we got through this, right? The second thing is the contracting process, right, in terms of procurement and attorneys involved, right, how to make that sort of simple. And what we've done for our clients is, because they've right, they've already had their procurement, they've already had their security vet our company. Once we've vetted the solutions to be part of the formulary, they can just we can turn something on and off at a client level with the simple contract addendum, right? One page and we're off to the races. So once we get through the initial period, and what we've done with our own procurement, our own contracting, our own technology organization is how do we speed that along? And we had to develop some muscles that we didn't have as a big company in order to be able to do that.
In the looking out, like when you think about this, think of how you've had to react over the last year. Like this is kind of a safe free zone where we don't talk about the,
we don't say those words, even though
we don't say those words. We don't talk about the plague. The plague.
Yeah, this C19. There you go.
Okay.
Yeah. How is that, like, so when you think about like what's happened, is it a complete revisit of the strategy over the last year? Has the organization been jarred in new ways, and do you see that carrying forward? Or
yeah, so I would say in 2019 we weren't planning for it. We would have to innovate around the pandemic that was to come, right? Although pretty early, late in the year in 2019, you got to write a lot of what we do is what's on the horizon, what's coming, and what can we do about it. And so it became part of our own agenda of what could we bring to our clients that could help get through that. And so whether it was at first tracking and understanding risk factors, knowing that people were home and not accessing primary care, people like going undiagnosed. We were among the first to report the changes in the use of mental health medicines, right? This giant spike, to 20-30% increase in the use of anxiety medicines in just the period before the lockdown, February. Issues with regard to people with emergencies not showing up at the emergency room or the hospital. And even now, still doing work around documentation for vaccines and promoting vaccines. You may not know I'm on the Vaccine Credential Initiative, now the Verifiable Clinical Information Initiative. But how do we help our clients get people back to the work site safely? How do we, the return to normal? And so because we're paying claims, whether they're pharmacy claims and our clients are paying medical claims, we actually have in our data set the fact that you got vaccinated, what you got vaccinated with, did you have your second vaccination? So today in our company apps, we're able to show you, and you can show anybody you want that you've been vaccinated and adequately vaccinated. And later this summer, we'll be launching the QR codes that go along with that. So it's not
just as a side anecdote, I just got my second jab and at CVS. So I asked if there's a digital version of the card and said, well, we can print out your record. I'm like, no, I mean like literally digital, not to print it out. So I just thought it was kind of funny, but
when we started, we, some of the, there were threats against us, of what are you doing? Like, this is, you want to make us get vaccinated, right? Whether you get vaccinated or not, that's up to you. But everybody who gets vaccinated is worried about what's happened to their card, right? You don't want to lose it if I have to get it again, right? So everyone should have digital access to their vaccine records and all their health records if that's what they want. And that's really what
I scanned mine and then I laminated it in a nice thing. So just saying my 2 cents on it. And actually, so during this, you kind of mentioned even access to care during that time. I think that's when I'm curious if the C19 expedited your MD Live.
Well, it definitely expedited virtual care or telephonic care and video-based care because people needed to have access, and it accelerated for the health systems and practices themselves. You had to do it. What's really been interesting from my perspective is that for many practices, it's not really the way that they want to practice. Because it's not in line with the revenue model, You can't do a procedure to somebody if you can't touch them, and they're not there. So the revenue per case, if you're an institution. On the other hand, when we think about a virtual first type of practice as we have with MD Live, right? That's not the model. The model is how do we help patients who are beneficiaries of the plans that we serve get cost-effective access to care. And whether that's primary care, whether that's mental health care, and mental health care, right, has been a great example, right, that there's not a lot of touching. In fact, if there's touching, there's probably a problem and somebody's going to go to jail or get their license suspended. But right, it's a great use case for virtual care. So we're very excited about having MD Live as part of the family, and it's a good example, right, of has us thinking right now, if you want to scale the ability of a licensed provider, a physician or a therapist, how do you make it such that they can take care of not 1,000 patients, but thousands of patients or tens of thousands of patients,
Right.
And you have a digital complement to that, makes a lot of sense.
And Eugene, this is an important question. And what was Eugene like to work with, like 10 years, what was it, 15 years ago? Like, what was his?
I'm gonna mute Glen right now. Hold on.
Okay, so Eugene, as I'm sure it wouldn't surprise you, was both very high energy. And there was nothing that couldn't be done.
Like it.
Good answer, Glen. Good answer. Yeah. We will release this episode. I'm actually curious. So obviously, now this conglomerate, right, of different multi-businesses, and then we're seeing, and I don't know how much you, Glen, tracking a lot of these, 100 million here, 300 million, 4 billion SPAC, 2 billion SPAC, and everything from primary care to digital therapeutics to things that, in some cases, may have some revenues, but what's really the impact to the patient? How are you looking at this, thinking of this, if at all? I don't know if that's in your daily agenda, right? But
so look, we have a venture fund. You've seen us be active in M&A. We have to think about the world as being diverse. There aren't single solutions that are going to work for anybody in anything, right? So if you want to take care of a whole population, or have something for all people, you have to think about partnerships are important. You have to think about there are some assets that probably make sense to own, and they're probably or to be invested in to accelerate because things have, and to be so self-centered to think that we can invent everything, right? It's crazy. And so it's some combination, but if you're externally focused on what are the problems that your clients have, what are the problems that the people that you serve have, and how to get at solving them, you'll figure out, what combinations make sense.
Love it.
And where are you looking ahead, right? Like if you rewind back to like 18 or 17, maybe yes, like virtual care and visits were somewhere on that innovation agenda. Kind of where's your head if you kind of fast forward, you had the crystal ball in the next 5 years?
Yeah.
What are some key items for thoughts?
Yeah, I think that it's the combination of digital and processing of information and automation and AI for assisting decisions, right? I don't think we're at a point yet where you're going to take chemotherapy because the computer said this is the one for you, or this is your diagnosis. But there is a way to use probabilities to help and prevent mistakes, and also get to the right answer faster. And so that's one. And the second is, if you really want to help people change their behavior and help them have healthier behaviors, right, you have to think about them in their milieu, right, in their setting. And they spend a lot of time at work, and they spend a lot of time with their families and at home. And if we have to think about
last year is one of the same, by the way, right?
But look, if you want to make it easy for someone to do the right thing, and you want to make it hard for them to do the wrong thing, you have to have solutions that work in both of those environments and complementary, and bring in the people who care about you maybe more than you care about yourself, to help you and not annoy you, right? And so I'm very interested in how we can create the support in both of those environments to help people achieve the health that they want, right? Nobody sets out saying, I want to be morbidly obese, right? I want to have heart disease. I want to get sicker. The reason that it creeps up on you is because doing all the right things is hard. And even if you do the right things, right, there's not a guarantee and you got to enjoy yourself. That doesn't, right, it doesn't mean, and we also have this, right, we tend to blame people for what happens to them, which is, you know, completely not right, right? If all this were easy and we were all wired the same, right, it would be different. But we have to create the supportive environments and meet people where they are. And just coming back to the digital piece, right, they're often on their phone, right, and their smartphone. And so, you know, how can we use that for the right nudges, right?
Awesome.
Though I've been seeing some people saying taking a complete like once a week detox from phone, and apparently it's just like invigorating. I think I'm going to try that, Jim, on a Wednesday.
Totally.
I can see you starting to twitch already, Eugene.
Yeah. Jim, do you want to go to your, your famous ending question?
Right. So you're a recent. Imagine yourself like just out of medical school, and you've decided to go into digital health technology and start your own company. And you're thinking about space. What advice would you have for that young doctor that decided to become an entrepreneur versus a doctor?
Yeah, I would, you know, sort of take the lesson of, you know, all of the companies and others who have come before you, including, and I won't mention names, but large employers and large technology companies who put together to tackle the problems of the world together collectively. They have a large population. You have to be in the flow. If you're not in the flow, no one will adopt your solution. If you don't have access to the data, if you don't have access to timely data to be able to connect and observe, right? You can have great ideas, but they won't get adopted. And so it's really understanding who you're focused on, what's their problem, why does it matter about solving it, and why is it better than whatever they're doing today, and how are you going to get it in their hands? You know, at least I look at what we're doing at Evernorth and our partners in digital health. That's what we're trying to help them do, right? We are witness to the people who need the solutions, and are trying to help get it connected to the right people at the right time.
Awesome. In the flow.
Awesome. In the flow. That's what I took down as well. Glen, it was a really, really awesome to reconnect again. And thank you for making the time.
Well, Jim, Eugene, thank you very much.
Thanks, Glen.
And for those millions of listeners, pass this around, hit the follow, subscribe, and see you in the next one.
Bye-bye.